Good afternoon, everyone. Lovely to see you all. Just give me a wave to make sure you can hear. Awesome. So my name is Debbie Barham. I'm a palliative care specialist here at Hospice Waikato, and I'm your friendly facilitator today, along with the team here. I would like to start by welcoming you, and we'll just go around the screen and check in who's here. So if we just give you an indication, we will manage the muting and unmuting from this end. But if you could introduce who's here and let us know where you're based at the moment, that would be great. So if we start with Julia. And we may need you to unmute things, Julia. Thank you.
Okay.
Thanks, go ahead.
Hi, just put your sign up. Can you read?
Awesome, welcome.
Hi.
Is that better?
Can you hear me now?
Fantastic, yeah. Thank you.
So today I've got with me, I'm Charmaine.
Welcome.
I'm Marianita.
I'm Tony.
Welcome team at Tamahia, nice to see you.
Thank you.
Thank you.
We'll drop down to Evelyn Gerrish.
Hi, I'm Evelyn. I'm a palliative care advanced trainee, and I'm currently working in Tauranga Hospital doing medical oncology.
Welcome, Evelyn, and thank you for sharing the teaching with us shortly. If we drop down, we next have Gerrish.
Hi, this is Raj. I'm the clinical manager from Eventhorpe Rest Home. Sorry, Gerrish is not here. I'm using his slide.
I thought you looked a bit different today, Gerrish. Welcome, Raj. Nice to see you.
Same here. Thank you so much.
Okay, if we go across, we've got Hermina.
Yeah, this is Hermina from St. Andrews, and I've got Mihanas, our senior nurse, with me. Hi, Mihanas here. And the clinical manager, Joyce, will be joining us. She's just on her way.
Fantastic. Welcome to the team at St. Andrews. Nice to see you. If we go up on our screen, we have ECRN. Enigmatic.
Oh, no, not particularly. It's just what we put in. Sorry, we'll sort that out. Good afternoon. My name is Julia Corby. I'm the new clinical nurse manager at East Care in Hamilton.
Brilliant. Lovely to meet you, Julia. Thanks for joining us.
Thanks.
We'll go across to Debbie and the team at Aparangi.
Hi, so I'm Debbie Austin. I'm ARC Liaison Nurse for Hospice Waikato, and joining me I've got...
I'm Ali, I'm the Clinical Coordinator at Aparangi.
Nice to meet you, Ali. Thank you.
Thank you.
And up to the top we have Maddie and Brian.
Hi. Good morning, good afternoon, everybody. I'm Madeline and I'm a rural CNS, and we were just doing a clinic in Tamarinui on our way back. We are in Tikawiti.
I'm Brian Enton, I'm the Medical Director, exiled with Maddie and Tikawiti.
Lovely to see you guys. Halfway home. We'll see you soon. Thank you. And if we just go around the table and introduce the team based here at Hospice Waikato.
Kia ora everyone, I'm Virginia Lee. I'm a new social worker in the inpatient unit at Hospice Waikato and some community team.
Diddy, you know me.
Hi everyone, I'm Andrea. I'm the Education Coordinator and the Eco Coordinator at Hospice Waikato.
Hi, I'm Gail Brooking. I'm the Spiritual Care Coordinator.
I'm Adam. I'm the IT support.
So thanks for joining us, guys. Just a couple of small announcements, updates before we get on with the teaching. Just to let you know that the time you spend with us here can be kept for continuing education purposes. So if we have a record of who's attending, we can send you a certificate with that regard. Any announcements from anyone else? Good to go. So thank you. The teaching this morning, the format of our ECHO is to start with a brief didactic teaching session, and that's kindly being presented today by Dr. Evelyn Gerrish remotely from Tauranga. So Evelyn, just remind us when you need us to change the slides over, and we appreciate your time. Go for it.
Thanks. So as I mentioned before, I'm an advanced trainee in palliative care, and I was actually asked to do this talk when I was still working at the hospice inpatient unit, but unfortunately timing-wise meant it happened after I'd already left there. So have we got the slides, the first slide up?
Just a moment.
So I've been asked to talk about diabetes management and palliative care.
Okay, just give us a second, Evelyn. It looks like we've still got the introductory slide up. Let's go, just give us 1 minute to see if we can sort that out for you.
Yeah, keep going, keep going. Yes, next one, next one, next one, next one. Yes. Oh, yeah.
There we go.
Okay, that's good.
Hopefully, can you all see the slides here with objectives on it?
Yes.
Go
Great.
for it.
Okay, so hopefully in our brief talk today we can answer, or at least begin to answer, some of these questions, which is why should we worry about diabetes in palliative care? Does it really matter? What should we be doing about diabetes management at different stages of illness and also different types of diabetes? And just briefly, what about steroids and diabetes, as that's really common. Now, I'd have to say, on looking up about this, as with a lot of palliative care, there isn't a lot of good evidence-based guidelines out there. In fact, most are based on kind of expert opinion. The two main things that I've looked at and based this on is there's really good UK guidelines from Diabetes UK, on diabetes at the end of life, and also there's a little section in our palliative care handbook, the New Zealand one, which is worth a look at. Okay, so next slide. So diabetes in New Zealand, I think we probably all know that it's a huge problem. So it's estimated at the moment there's about 240,000 New Zealanders diagnosed with diabetes, and probably at least another 100,000 who are undiagnosed. So it's an incredibly common comorbidity, but sometimes we see that it's kind of overtreated or undertreated in palliative care, so both ways. Next slide. Okay, so if we're thinking about diabetes, what are the goals of managing diabetes in palliative care, and the kind of why should we worry about diabetes? So there's a few bits here if you click. So our main thing is, of course, to ensure good symptom control, which is the case for most things in palliative care. And click. We want to try and avoid hypoglycemia. So that's always the first rule of diabetes management, get rid of the lows. And click. But also we want to get rid of some of those highs, and there's some reasons for this. This is one, to avoid the serious metabolic problems. So that's things like the diabetic ketoacidosis or HONC, the big emergencies, but also we want to avoid those more chronic things. So things like the foot complications, pressure sores, particularly in bed-bound people, things like infections. And also, click, avoiding symptomatic dehydration. So of course, if we've got very high sugars, that can lead to dehydration. And next, we want to make sure that we provide an appropriate level of intervention for the stage of the illness. And lastly, also, and very importantly, is try and maintain self-management and independence where possible for our patients. They've often had diabetes for many, many years, and we don't want to take away that control unless necessary. So next slide. So what are the changes that can happen in our patients that could affect their diabetes management? Okay, so a huge range of things, and we can click through these. So of course, weight loss, incredibly common, reduced oral intake and appetite. They may have some nausea or vomiting. Changes in activity levels, so becoming less active for most of our patients. There may be metabolic changes associated with their disease. Steroids is a major one, so that's one that we contribute to as healthcare professionals. Infections can affect the sugars, often causing hyperglycemia, so high sugars. End-stage organ failure, particularly renal and liver failure, can have an effect on blood sugar levels. Disease-specific problems, so one of the big ones is pancreatic cancer. Of course, damage to the pancreas can lead to pancreatic insufficiency. So patients who previously weren't diabetic can become diabetic, but we can also get worsening of diabetes in those with pancreatic disease. And okay, next slide. So if we break down our patients into the stages of disease. So if we look at the first group, these are people who may have a new diagnosis. So they've got stable disease and a prognosis of around a year or more. So what's happening for this group? They've often been diagnosed recently with a life-limiting illness, and that may change our goals of treatment and, for their diabetes. They may also have reduced oral intake, weight and activity levels. Next slide. So what do we need to be thinking about these people? So thinking about their other medications, not just their diabetes medications, but do they still need things like their statins, aspirins specifically, particularly in people who might have a GI disease, or also people at risk of bleeding, and there are other medications like the antihypertensives and ACE inhibitors, and we may be able to reduce a lot of these. If we review at this point, it gives us an opportunity to simplify our treatment and also begin some negotiation on what are appropriate treatment targets, what medication, and what things we may see ahead in the future. HbA1 testing may still be appropriate at this point. And we also need to consider, some people have been on incredibly strict diets, and particularly if their appetite's reducing, then a strict avoidance of sugar may not be appropriate for these patients. But on the other side, we may avoid medication if people can keep a good diet at this point. Next slide. So now we move into the next group. So these patients are more unstable. They're getting advanced disease and probably with a prognosis of months. So what's happening for this group? So likely these people have a reducing oral intake, usually a reducing weight, and likely reducing activity levels. And it may be that carers are becoming more involved in their management of their diabetes as well as other management. Next slide. So what do we need to be thinking about in this group? So all of the above. Of course, I've put them into groups of disease, but people don't necessarily go from group 1, 2, 3, 4. They may even just be straight into group 2. So we need to again be thinking about reviewing their medications. Are there things that we can stop? Can we keep the interventions to a minimum for these patients and look at complicated regimes? So this could include, if they've got complicated insulin regimes, we may be able to simplify that. Once weight loss is established or reduced appetite starts, then one of the recommendations is actually looking at the oral antidiabetics and considering halving the dose of them. Those on insulin, again, maybe simplifying things. So maybe considering, instead of a more complicated regime, maybe moving to a once daily insulin. And if we're doing that from a more complicated regime, then we want to reduce that generally by about 70% of their previous dose. Next slide. Okay, moving on to the patients who now only may have weeks of life to live. So these patients are likely to be spending most of their time sitting or lying, and they're likely to have a significantly reduced oral intake and weight loss. So again, we want to review their regime in mind of this. And at this point, it may also be appropriate to be stopping their oral antidiabetics and other oral medications. Next slide. And lastly, our dying patients. So these are people who we think have a prognosis of days. So likely they're going to be eating and drinking very little. They may well be unable to swallow their tablets anymore, and they're likely to be bedbound. Next slide. And if you click. So what should we be doing for these patients? For those who are diet controlled or on metformin, actually we can usually stop their medication and actually stop monitoring at this point. Click. For those who are type 2 diabetics and are on other tablets, maybe with some insulin, usually again we can stop their tablets and review their insulin. So if they have really well controlled diabetes, their sugars are fairly good, we may be able to stop insulin. If it's needed, so they've got higher sugars, then again looking at can we change to just a once daily insulin. Click. So what about if they've got very high sugars? So if we've stopped all their medications or their insulin and they get high blood sugars, if they've got a high blood sugar, usually people aren't going to be symptomatic until they're getting up 15 or more likely 20. So then we can give a small amount of some fast-acting insulin and check a blood sugar a couple of hours later. If you're needing 2 or more doses of fast-acting insulin, then thinking about a once daily insulin. And again, at that, about 75% of the dose of the fast-acting insulin you've given. Next slide. Now, one group we really need to think about is the type 1 diabetes. And the big takeaway from this is don't stop their insulin. So with type 2 diabetes, most people will still produce a little bit of their own insulin, but if you've got type 1 diabetes, we need to assume they've got no insulin production. We can usually stop as they're reducing their oral intake and eating very little. We can often stop that fast and rapid-acting insulin around meal times, but continue with that baseline basal insulin until they die. If we're checking their sugars, then thinking if they've got a low sugar, so considered below 8, then thinking should we reduce their insulin by about 10 or 20%, and if they've got very high sugars greater than 20, and looking at increasing their daily insulin by 10 to 20%. And these patients have often had diabetes for many years and are well controlled. They know what to do, but we may need to be starting to take over some of their, giving their insulin as their function deteriorates. Next slide. So if we think about numbers, like I said before, there's not a lot of evidence-based for looking at numbers, but the numbers that most guidelines suggest is that our aim is ideally we don't want low sugars, so thinking anything under 6 millimoles per litre. Ideally we don't want any of those. And if we can, keeping the sugars between 6 and 15, so ideally no sugars over 15. Once we get to 15 and up to 20, that's usually when people might develop symptoms. As mentioned earlier in the disease, then those with months to years of prognosis, then we may still want to monitor their HbA1cs, but usually wanting to relax those targets. So instead of aiming for maybe 50, we may relax it up to 70. Next slide. Okay, just a few bits about medications. So just to consider, so for metformin, we need to really be considering the dose with reducing renal function and stopping if they get severe renal impairment with an eGFR less than 30. Need to be considering the GI side effects. So for a lot of people, metformin gives a lot of stomach upset and diarrhea. So those who have, bowel disease may not be able to tolerate it anymore. Sulfonylureas, which are the other common medications, remembering that they do come with a risk of low blood sugars, and also doses need to be reduced with renal and liver function deteriorating. Next slide. Insulin. So again, these may need to be reduced with changing oral intake and activity levels, and also the doses need to be reviewed with deteriorating renal function as well. If they're not eating and drinking, then we can get rid of that rapid acting insulin, and we may be able to reduce testing. So the recommendation is if they're on a once daily insulin, then just doing a once daily test prior to their insulin dose. And remember, for type 1 diabetes, don't stop their insulin. Next slide. Okay, what about steroids and diabetes? So of course, steroids are used a lot in palliative care for a number of reasons, sometimes for symptom management and sometimes for more significant issues like spinal cord compression. We need to be, cautious about using steroids in people with known diabetes. So thinking about it, are we going to need to check their blood sugars more often? Are we going to need a change in their treatment? But steroids may also unmask a diabetes that we haven't previously known about, or those with impaired glucose tolerance. Studies have shown that the effect on blood glucose correlates to the dose of steroids. So those patients who are on high dose steroids are more likely to get changes in their blood sugar than the people on a low dose. And ideally for all patients that we start on steroids, we should be checking a blood glucose level prior to starting. And if we're looking for steroid-induced diabetes, the blood glucose levels are best checked in the late afternoon. That's when we're most likely to get a higher sugar. Next slide. So what should we be doing about patients who develop steroid-induced diabetes or worsening diabetes on steroids? If it's just a short course for something like 3 or 5 days, we may just need to monitor it. We can consider weaning or stopping the steroid, but also being mindful that studies have shown that even on stopping steroids, some people will continue to have high blood sugars. If they have high blood sugars, considered greater than 15, then we can treat it like normal diabetes. So considering adding a sulfonylurea, a medication that we would, that we could give orally, or a once daily long-acting insulin. And these are recommended ideally in the morning. And of course, if we're changing doses or weaning or stopping the steroids, we need to review our treatment again. Next slide. What about some of the challenges of managing diabetes in palliative patients? So one of them, like a lot of things, the symptoms of diabetes, the hyperglycemia or hypoglycemia, can be similar to that of a deterioration or dying. So fatigue, feeling unwell, feeling, having some nausea, those may be signs of high sugars or low sugars, but that can also look like a general deterioration and dying. Some people may see that us reducing medications, reducing insulin, reducing the frequency with testing, some patients may actually feel like this is us giving up. So I think the earlier we can start discussing that we're going to be making changes, the better. And as with everything in palliative care, really good communication. And others may see that diabetes management, once they have a terminal diagnosis, is pointless. So again, explaining to them why keeping the blood sugars at a reasonable level can improve their quality of life. Next slide. So takeaway messages from this is, so remembering that appropriate management of diabetes can add to good symptom management and improve quality of life. We need to consider the goals of our treatment according to the stage of disease and adjust our treatment appropriately. Really important to negotiate interventions and targets with patients so they don't feel like we're over or under treating them, that we don't feel like we're giving up on them or don't care anymore. For steroid-induced diabetes, we need to be thinking about it with any patients who are on steroids, and ideally afternoon testing, but morning treatment if we're going to start some. And the other big one, if you haven't already taken this away, is type 1 diabetes, don't stop their insulin. And that's the end.
Brilliant. Thank you so much, Evelyn. That's a big topic to try and cover in a short space of time. Does anyone have any specific questions for Evelyn? Bearing in mind these slides will be available to people afterwards, but if there are any comments or questions. Okay, thank you. I'm just aware that during that presentation we were joined by another person. So Tom, we'd just like to welcome you. You are on audio but not video at the moment. For people remotely to be aware, Tom Reid is another palliative care physician based here in the Waikato. So thank you and welcome. We're going to move on to the patient case presentation. Nice to see you, Tom. Well done.
I just wanted to say thank you very much for a great presentation, Evelyn. I was keen to see on the diabetes advice, so very interesting. I may have to sign off there, but thank you. I managed to catch most of that. Sorry to just pop in and out.
And I have to say, I'm sorry, I have to leave shortly because I have a clinic patient to see at 2:30.
Carry on the great work, guys. All the best.
Thank you. Thank you both. So we're going to move on to the case presentation for the team. If you've not joined us before, this will take the format of a presenter. Brian is going to present the case today along with a couple of key questions. We'll summarise that and then give you an opportunity to ask any clarifying questions. So just be taking note of the case as Brian speaks. We'll clarify, make sure everyone has the information, and then we'll open it up for discussion for recommendations thereafter. So Brian, thank you for your case. Take it away.
Thanks, Debbie. Given that the participants today are knowledgeable more in residential care, the key question really, and it fits just as well, is about the pros and cons of treatment in the inpatient unit versus a transfer to aged residential care, and what sort of help and benefit and complexity needs to be handed over to residential care. This is a bit of an everyday problem. It's not particularly, it's not particularly in everyday patients and aged residential care, but it certainly happens. A young woman who was previously fit and well, who was diagnosed with a nasty neuroendocrine pancreatic cancer in May 2018. And having nodal and liver disease at diagnosis meant that surgery wasn't an option, and she had some limited chemotherapy options. So she has been living in a regional centre at home. She has teenage and one older children. I think they're all living at home. They have good family support, and she works pretty hard on these 12-hour shifts with heavy machinery, and I mention that because it does influence medications and things like that. The background of the disease was the diagnosis last year, and initially some sort of response, but then at the beginning of this year, that response was lost. She had progressive disease. She needed a liver stented. She came into clinic for problems with pain and nausea, which are the common symptoms that one gets with a pancreatic tumour. And this held things at bay for a little while, but in June she came into the unit for symptom control. Now, the physical medications / interventions, I've really just put the briefest of summaries there, and this is actually an issue for people to discuss in terms of how much information do people need on discharge. In May, the clinic appointments started on Maxilon and Creon, and a lot of pancreatic patients end up on those things, and a celiac plexus block, which we're trying to do earlier rather than later now. When she came into the inpatient unit, it was both, I'd put nausea, but it was actually for nausea and pain, and sometimes these people get nausea from their pain, if that makes sense to you, that you actually can't control the nausea without controlling the pain, and a bit of vice versa. And so to summarize 3 weeks of changes, I put starting a syringe driver, varying doses of Maxilon, haloperidol, Nozinan. Nozinan was very sedative. Ranitidine, more commonly used just to get the acid out of the stomach now. And methadone was certainly the most effective thing for her pain. We pumped up the omeprazole, we continued the Creon, and we adjusted everything because very easily she became sleepier than she wanted to. And this was a woman that was working not so long ago. Some days she felt good and was active, but only for a day or two, and sometimes the notes were called in the morning, feels good, and then in the afternoon feels lousy. We added some olanzapine, we took the Nozinan out, we swapped the fentanyl, and after a couple of weeks, he was feeling good, keen to get back home, and so we knew there was some vulnerability, but she was keen when she was discharged home on Maxilon, haloperidol, methadone pump. The steroids were reduced, the ranitidine was stopped, but very quickly after getting home, she needed readmission. And living regionally, she tried Gerrish Hospital, but they didn't feel that they could deal with the symptoms, and the request was made out for readmission. Now, amongst all this medical stuff, there was a significant amount of stuff done by counselling and social work for her and for her family. Again, the details are unimportant. The specific details are unimportant, but that's the question in terms of how much, now that we're going into aid residential care, needs to be handed over and why. Struggling a little bit for ethical issues beyond the obvious one of the resources for preferred place of care, and the resource that we can use in the inpatient unit does not equate to the resources that are used in a residential care or at home or even a regional hospital. And this little addendum, if we want to touch base, is I, without fail, seem to have a cannabis conversation at any consultation, and we're still learning what to do with this in the inpatient unit. Do we offer it as an alternative for appetite, nausea, and pain from our own stock of medicinal cannabis, as Tilray or whatever, and what happens when somebody goes into residential care with a controlled drug, or if they're using it their own, how do we store a controlled drug and handle that in residential care. A little comment, she was booked in for a teleconference, and that's one way that we can talk about as to how helpful that is out in the community. So that's the case, and so the question is, you're getting a young woman transferring, which has quite a complicated, well, a very complicated admission to the inpatient unit, and is it fair, and how do we cope with the transfer for such a woman into aged residential care? And yes, it does happen. Thanks, Debbie.
Thank you, Brian. So interesting case. From our end, just to summarise then, a 41-year-old woman, previously well, with now a progressive malignancy, complex symptom management, number of medications, number of ethical questions, but perhaps focus today on how best we look at this transition between specialist service and community services with a focus on aged residential care. Is that a fair summary? Yeah.
Muted. I'm not muted. Think that's good.
So first, before we begin to offer suggestions, an opportunity to just go around the room and ask people if you have any questions or clarifications, things that you would like Brian to elaborate on further, any more information you require. So just give me a wave if you would like to ask anything extra. Sounds like you've done a great job then, Brian. All clear. So opportunity really to think wider, and I'm aware that the focus is often on all the medical sides of this. It would be really nice not to focus on the medicine, but to focus on the person, and to focus on communication and collaboration, how best we do that. So before the team here comment, we would love to throw that out to the teams out in residential care one by one. So have a chance to think, if anyone's brave enough to go first, to raise what might be questions or what might be some solutions or suggestions. Thank you, Julia. Lovely. Kick us away. Go for it.
Hi. I guess what's going through my mind is, as it's about the communication, and really when somebody is being transferred from one area to another, it's about how that transition process occurs and what happens during that process, to try to ensure that when the person arrives in the facility, that everybody feels confident about what the goals of care are. And I guess mine and Debbie's role is really there to try to help facilitate that, but we're not the only ones who are part of that process. But I really feel that it's all about the conversation, it's all about the planning. That's really the fundamental thing that I really hear quite often. If only we'd known such and such, that might have made a difference for people who are working in aged care. What do you guys think? Yeah? Anything you'd like to say? Or? No? No? Okay.
Thank you, Julia. Perhaps before I put anyone on the spot, an opportunity to ask those of you working in aged residential care what you see as the biggest challenges. What are the barriers to communication? Perhaps not, specifically what did we not write on the form, but what are the things that would be most useful to overcome those challenges? So we'll come back to that question, but anyone else want to add at this stage? Perhaps Debbie and Ali at Aparangi, have you got any comments to add, Debbie, from your perspective?
Just from a recent experience that we had from an IPU complex patient coming into an aged care facility in Cambridge, that discharge was fantastic. There was great communication with the staff and the facility manager. There was inclusion and discussion with the GP. And myself and the IPU nurse actually did a transfer together with the patient to the facility to help stabilise that transition at the time. And the hope was that we would avoid another readmission to IPU or to the hospital, and we managed to achieve that. And that lady actually stayed in the facility and was very well cared for under the instructions that the IPU had delivered to the facility, and with close collaboration with our specialists and the GP when problems actually arose. So that was a really fantastic example of how working together with aged care really worked. So maybe that's a model we can think about.
Great, thank you, Debbie. Just a reminder, people to remind each other that this needs to be confidential, so just try and leave out identifying names of places or locations. That would be great. In terms of managing that communication, it's great to have good examples. I guess one of the challenges is about the resource necessary to achieve that. So useful to hear what people think are the must-haves. Any comments from the aged residential sector about the things that have worked really well, perhaps not this specific case, but others, as Debbie shared? What have been the things that made a difference? So Julia at East Care, thank you. Go ahead.
I'm extremely new to aged care. I've done a lot of it back in the UK, but I've come from acute. But and this is actually only my 4th day here. But in that short time, I think the things that are important when residents are coming into care is the specifics to them. So the family support, bringing their own personal things with them. The potential issues seem to be getting things done quickly enough, because if somebody's moving in for end-of-life care, it's the issues of getting everything done together so that the whole family is involved, the whole team is involved, and it all comes together as quickly as possible. And I don't know, I mean, things do seem to be very efficient, but it has to be client and family centered, I think. But yeah.
Thank you, Julia. That's a really key thing, I think. Thank you for sharing that the family, not just the patient, but the wider family context needs to be front and centre with everything we do, but particularly these transitions. Raj, do you have any comments from the Even Thought perspective? Oh, sorry, Raj, we can't hear you. Are you able to unmute things at your end?
Yes. Is it okay now?
Thank you. Go ahead.
Sorry about that. So it is usually, as it has been said before, it's usually we have to work with the families, and it's really helpful when hospice help us as well, because we do get quite a lot of palliative patients, usually with these kind of condition which we have, like cancers. Usually the myelomas are quite common in our facility. So it is really good to work with DHB or hospice, and if we can help the families more, because some families, they cannot really understand like what is happening with their loved ones. So it's sometimes really hurt to see them like that, I think, when they cannot cope with the situation. Yeah, I know like hospice is really good at do counseling for the families as well, and we do refer even families to the hospice as well, just to help with them, because sometimes patients are okay, but the families are more affected by patients' conditions. Yeah.
Thank you, and that's a really important point, that it's not just about the patient. It's so similar to, as Julia just said, that we can't just treat a patient in isolation, that this is bigger than that. Thank you. Hermina and the team, have you guys got any comments or questions? I'm sorry, we didn't catch that. Would you mind repeating?
For us, we are really glad to know that you guys are out there for us to support, and it has been a good experience all this time. Yes, we have some situations where we needed help for have support for our family who's involved within the care of the patient, and for their support and counseling. We had one of the hospice nurses that intervened and helped us out. It was really good, and it helped the situation, and it also assisted in having some of the medications that was out there that we weren't sure that we could use, and helped to get it in place, and we got the doctor involved, and it was done within like less than half an hour. So those things are really good, and yeah, we have a good support already from hospice to us, and hope that continues. Yeah.
Thank you for your comments.
And also, we found out quite often that residents transfer actually from hospital and back to the facility. So sometimes they really need palliative care, hospice like support. But quite often that they actually, it's better for them to have that involved, have hospice or palliative team involved before they actually transfer back to the facility. So we have a better understanding about the cares and what actually going to happen next. So it's not good to leave to the facility to actually get things done, because that leave some gaps from the patient actually transfer back to the facility. And once we get in touch with the hospice and get them involved, sometimes it's a delay about the plan of the treatment. That's quite often what we found.
Thank you, and that's something valuable for us to be feeding back to our hospital-based team and to our colleagues that don't work in palliative care in the hospital. Thank you. If there's nothing else remotely, then I'll just open it up to the team here in the hub. Anyone else want to make comments, questions?
Brian, I don't know if you said on the case study, but was it very important to the patient from a social and spiritual perspective to be close to her home area?
Yes, that's where whānau are, and it's only the severity of the symptoms that means that she's had to shift out of area, but can we somehow do it in the area? We can't answer that. We can't answer that today. Because I've got the floor, the question that does come to mind is picking on yourself and perhaps the new social worker, because these are disciplines that aren't available in age residential care. Tell me I'm wrong. And what sort of communications and handover, because you've got nobody particularly to hand over to. How important is that? Because as a doctor writing a discharge summary, I'm not putting details about the work that you guys have done. How does that get through?
I'm happy to speak to that, just from a small perspective. I wonder sometimes when families are quite large, a lot of the members of the family don't know who to ask or have different ideas. So some things that can be quite helpful is for a social worker to be able to hand over to one member of the family as well as to the facility, that as much is done as possible so that loose ends are tied up as much as possible, and it's almost one person from the family can hold the story of what's happened. Would that make a difference in aged residential care so that you still are clear? So that you've got one go-to in the family as well. This is with family discussion and consent. Yeah.
It's a good suggestion, thanks.
Yeah.
How about Gail, from a spiritual perspective, how do you handle that transition?
We do have regular network meetings with the rest home chaplains. So we are a group who know each other quite well. So it's definitely worth giving us that information that we can have a conversation with them before the patient gets there so they can follow on with care. And we also have some resources for the rural areas from volunteers from different faith communities. So again, a bit of advance warning before the patient transfers would be really helpful to arrange some ongoing spiritual care for them.
Thank you. I had one question to ask the team in aged residential care, that I find it challenging that even we call it aged residential care. This is a young woman who is in her 40s, and we acknowledge that there really isn't another option for people when they're requiring care at hospital level. It really is being done in aged residential care. What are the particular challenges with that from your perspective, or what are the things that might make a difference to improving that? Have you any thoughts? Go for it. So Julia and the team at Kimmer here, thank you for volunteering.
We try, I mean, I know we're repeating ourselves to a certain extent, but we try to be completely patient-centered. So to a certain extent that makes it simpler because you are dealing with the individual. So that particular client with those difficulties would be a complete individual. So the culture is very much individual patient care. So for us, that would not necessarily be an issue. The level of care required, although we're not hospital care, we are residential, we do have also in our dementia clients really some very sick people. So we are, you know, as you say, we talk about aged care residential. It sounds as if it's just a lot of elderly people pottering around drinking tea and eating cake. Well, it isn't. And a lot of our clients are very old and very sick. So we would be able to, and I suspect a lot of residential care establishments would be able to cope as well. Yes, we could cope with that level of care required. It's, I mean, we have open visiting, so they can come when they like, and also for our clients as well, going back to what Brian was saying, that we have a gentleman at the moment whose wife lives literally just round the corner, and she is absolutely terrified that he's going to be moved further away because she wants to be close to him. They've been married for 53 years. Families want to be able to just pop in for 10 minutes, have a quick cup of tea, pop in before work. So those are the important things, the family orientation, and as Brian says, the being able to pop in because you live just across the road or just around the corner. And then as long as we are geared up to and used to looking after quite sick patients and making sure that all the planning is in place and the care plans are in place, it's I was going to say it's comparatively easy. That's not what I mean at all. But it's not a huge step, particularly, well, for us, and I suspect for a lot of other places.
Thank you, Julia, and I just want to validate the wonderful job that you do in residential care, that we recognise that this is home for these people. You know, home is where the heart is and where the person is. And so you do a great job in making your facilities these people's homes. To the other Julia up in Kimahia, I think your team had some comments as well. Thank you.
Yeah, I think the challenge is, you know, when you accept young ones, you know, in an aged care facility, normally, like maybe 95%, we do accept 65 age over. So I think in the past we did have like a 30-year-old resident. Yeah, the challenge was that, of course, you need to establish your, you know, trust, you know, and rapport towards the resident because of a young age. And, you know, you would ask yourself, how would, you know, the client feel of being here in a mixture of over 65-year-old clients? Well, in the end, we did get her trust in a way, yet we go back on an individualized care plan, assessing, you know, what the needs are, you know, holistically. You know, you just don't focus on one area. Like this client has got young age children, like maybe under 10. So yeah, then how does the children feel at a very young age? So I think in the end we did, you know, hospice got, you know, support, you know, from other, you know, support agencies, you know, with how do you call that? A social support system, you know, with the family, which is really quite good as well. I mean, and the second one was they were too emotional at a young age, and I think in the end they didn't quite accept that. Yeah, so I think we as nurses, we need to just, you know, be there, you know, support them emotionally, I mean spiritually, if we can give that one. But at the end of the day, we just have to respect, and then know, you know, identify what their needs are. Yeah, and then just this recently as well, we did realize that hospice can actually provide, you know, something like, you know, we have got a client who was really fond of a rugby team, so we did have that, but in the end the client died. So yeah, so just a good thing, because hospice is very open to, you know, support, especially with us. So I think you guys are very actively supporting us, you know, even though we're not on a remote area. So it's really good.
Thank you. I think one of the comments I wanted to make to that too was that the community of care and residential care, or in rural communities in particular, we sometimes forget the other residents in that facility can also be involved in caring for people. This is a home for these people, and they care about the person in the room next door or down the corridor. And sometimes there's opportunities to harness that for good and to share stories and to learn from each other, and for residents to be actively involved in providing not the physical cares in a medical sense, but the emotional, spiritual, social component to whole person care. So I guess, you know, are there opportunities in your facilities to be fostering that, to be including other people, and using their backgrounds, their talents, their skills, their stories for the benefit of others? Any comments from the table? Anything else you want to add? So I guess just to revisit one of the ethical questions, Brian, that you brought up about medicinal cannabis, particularly in this setting, but my question being, you know, treatments or managements or options that are a little outside the box. So things that are not the ordinary medications that your team are used to, or management strategies that you don't always do. How do you approach that, or how are there ways that we could be considering those things? Any comments, questions on that regard? So thank you, Julia at East Care.
One of the very interesting things that I've discovered in the 4 days I've been here is that here, if a resident is for instance has not had the bowels open for 2 or 3 days, they don't fill them full of lactulose. They go on to a thing called what is it called, active tea or something. And so that's a first line to try and do things a bit more naturally and a bit more gently rather than medicating everything. Then they have another thing for those, so they have chamomile tea. So if a patient is not sleeping well or upset or whatever, their first line is chamomile tea or relaxing tea. So there's a very gentle start, and then we start looking at the medication side of it if it doesn't settle. And for me, that's a new way of managing issues and behaviours, if you like. And it's really nice because it's not bashing everything straight away with a medical and medication and dragging the GPs into things that we can at least initially manage ourselves. Arnica cream for bruises, for instance. All this sort of stuff, which is a gentle way of doing things. So that's good.
Great. I think we would emphasise the role of non-pharmacological strategies for most things, whether that's physical symptoms or emotional, spiritual. The very medical world tends to throw medications at things easily, and we all like to support other strategies for that. So it's great to hear your team are doing that. Any other locations want to share any particular challenges or strategies for managing those out of the ordinary situations? Or perhaps, yes, please, Virginia.
Can I just, going back to Julia Ward's team, I think one of the other out of the ordinary is, as you said, what happens when there are young people who come in. And actually the impact of that on staff, when often you see death within the context of an ageing community, and suddenly the staff are jolted with people maybe their own ages. So just recognising the impact on staff as well as on other residents, as well as, of course, the patient and their own family.
Thank you, Virginia. Good point. Maddie, I think you'd like to add something. Go for it.
Hi, it's Maddie. I just wondered about, if there is something like that and you are going to perhaps use cannabis well, is perhaps to have, like Julia said before, a communication with the team and see how you can work together to put a plan together to make it safe for the patients and families.
Yeah. Thank you. I'm aware we're running short of time. Brian, did you want to add something?
No. If we're running short of time, the gold standard may be, as Deb was describing, that one of us pitches on admission to the age residential care. And certainly, when we started doing that in Wellington, we relieved ourselves of a lot of complaints that was coming back from that transition. I don't know how commonly that's able to be done, that one of our staff can actually, if not meet them at the new place, but that day actually front.
Yeah.
It's great if it can happen. I'm not sure how much it can happen. Maybe we reserve it for our most difficult.
Yeah. Okay, it's me again. We had a really complicated patient a while ago, a young woman as well that needed to go into aged care. And what we did then was before the patient was actually discharged, we had meetings with the team and just to discuss how, and it didn't work out well. It all fall to pieces, but that wasn't the reason for it. But we had meetings and they knew what to expect and what the difficulties we had. So it was actually quite good. And afterwards to debrief about it and to see what you could have done different.
Thank you. So I'll just try to briefly sum up. Thank you for participating and thank you for your comments, everyone. I think this case illustrates the importance of us working collaboratively I just want to acknowledge the wonderful work that is done in aged residential care in particular, as those of you have joined us. You know, and I love Julia's comment that we can do this, we do this. You know, that sometimes there's a sense that, you know, we are the experts. Actually, at the end of the day, the patient and their family are the experts. Our role is to come alongside them and create a community of support. And some of the things that we've sort of summarised that help to establish that would be clarifying goals of care, clarifying management options, communicating that very clearly to all members of the team, including the family and the nominated person perhaps for sensitive information. Where there's opportunity for us to do that face-to-face or to front up and do that in person so that we can be clear about what we're communicating and expecting, for things to be done in a timely manner, so we're doing that quickly, we can respond quickly, acknowledging that there are networks outside of your own setting, as Gail was mentioning, that we make sure we include all of those networks in our communities of care. Looking at not just the medical aspects but wider, both pharmacological and non-pharmacological things that support whole person care. And I guess the take home being that this is all patient, family, whānau, community centred, individualised, and that planning and communication are key. Hope that summarises things out well. Thank you all for your participation today. We really value you joining us. It would be really lovely if you join us next time. We'd love to have cases from your own personal experience that we can discuss. So if Andrea contacts you, please do feel welcome to present your own cases that are challenging for you so that we can have this ability to communicate together about how we face these challenges. Just a reminder to people that the next ECHO session will be on Thursday the 15th of August, again at 2 p.m, so you'll be sent reminders and invitations to join us. Please let others know if you know there are others who may benefit from this experience. Thank you all for your time. No further comments, we'll leave it there for this month. Thank you very much.